The next lecture will look at the physiology of blood pressure and flow and see how the two are interrelated. So we'll focus on the interaction between these flow and pressure parameters in the circulation, and we'll try to examine how advanced measurements such as dynamic arterial elastance and cardiac contractility can be used in our clinical practice to aid the treatment of patients' hemodynamic instability, in particular hypotension. As blood is pumped from the left ventricle into the aorta, pressure is generated, and this pressure in the aorta, the blood pressure, can be described as either the systolic pressure, which is the maximum arterial pressure during the contraction of the ventricle, the diastolic pressure, being the minimum arterial pressure during relaxation and dilatation of the ventricles, or the mean arterial pressure, which is the average blood pressure in an individual during a single cardiac cycle. Mean arterial pressure, or MAP, is the commonly used measure of blood pressure, as it's considered to be the perfusion pressure seen by the body's organs. However, it is not the average of the systolic and diastolic pressures, as can be seen through the equation. We've touched on this briefly before when discussing afterload, but systemic vascular resistance is the resistance of flow of blood through the body's blood vessels in the systemic circulation. As blood vessels constrict, there is the increased resistance to flow, and systemic vascular resistance increases. As the blood vessels dilate, it's easier for blood to flow in them, and that is, there's less resistance, and SVR decreases. SVR, or systemic vascular resistance, is calculated from the difference between mean arterial pressure and right atrial pressure, divided by the cardiac output and multiplied by 80. Normal systemic vascular resistance is 8 to 1200 dyne seconds per centimeter to the 5, but it's frequently indexed for body surface area and described as SVRI, and the normal range for this is approximately 1800 to 2400. Systemic vascular resistance and the factors that alter it can be described by Poiseuille's law. Now, Poiseuille's law tells us that resistance is proportional to the length of a blood vessel and also to the viscosity of a liquid, and that is this case blood. It's also inversely proportional to the radius of the vessel to the power of 4. Now, clinically, this translates into the following. As we increase the length of a vessel, resistance starts to increase. It's harder for blood to flow through it. As we increase the radius of a vessel, then flow increases, there's less resistance. And as we decrease the radius of that blood vessel, it's like having a constriction, and the resistance becomes much, much greater. Now, the main site of resistance within the circulation is at the arteriolar level, and the most important parameter is the radius of the vessels, this area. We can see from the equation, small changes in the radius will lead to large changes in resistance because that radius is multiplied or increased to the power of 4. In order to obtain adequate flow, several organs, or vital organs such as the brain, the kidney, the heart, etc., depend on adequate perfusion pressure or arterial pressure in those conduit arteries. Mean arterial pressure can be described by relating Ohm's law to fluid. Ohm's law states that resistance is pressure divided by flow. We can change this to make it more physiological relevant to the body. Resistance is our systemic vascular resistance, flow is the cardiac output, and the pressure is our mean arterial pressure, the input pressure, minus the CVP. So in order to change mean arterial pressure, then an alteration in either systemic vascular resistance or the components of cardiac output, that is stroke volume and heart rate, are required. Blood pressure, flow in the form of cardiac output, and resistance, or SVR, are closely interrelated. It can be seen how these three factors are all interdependent, because depending on our systemic vascular resistance, for the same cardiac output, then we have two different mean arterial pressures depending on the resistance that they see. And conversely, for the same mean arterial pressure, if we have a high SVR, cardiac output will be low, compared to a low SVR, where cardiac output will be significantly higher. It's really important to understand these variables are interdependent and that one affects the other, and that adequate pressure does not equal adequate flow, and conversely, adequate flow does not necessarily equal adequate pressure. So our mean arterial pressure is the driving pressure that allows blood to flow to the organs. Assuming that resistance to flow remains constant, If organ perfusion was pressure dependent alone, then as mean arterial pressure increased, blood flow would increase, and as it dropped, our blood flow would drop as well in a proportional manner. Clearly, that is not an acceptable mechanism for most organs that need a constant adequate delivery of oxygen in order to retain them viable. And hence many organisms and many organs use a mechanism called autoregulation. And autoregulation is the intrinsic ability of an organ to maintain its constant blood flow despite changes in the perfusion pressure, and in this case, our mean arterial pressure. Between a set range of mean arterial pressures, blood flow will remain constant, and if our blood pressure or the mean arterial pressure goes up, then the blood vessel diameter will be reduced to maintain flow at a constant rate. And conversely, if mean arterial pressure drops, then our blood vessels will dilate to remain or to keep that flow same. It's important to understand that autoregulation only really occurs between set limits of MAP and autoregulatory range. Once the lower limit has been reached and then below this value, pressure and flow become dependent once again. Mean arterial pressure, therefore, must be systematically controlled so that pressures do not fall below this critical level or the lower limit of our autoregulation, because at this point, as pressure drops, blood flow to those organs will be compromised by a reduction in flow. Arterial pressure is controlled systemically through a variety of mechanisms, both for short and long-term control of blood pressure. The immediate response to a hypotensive episode is decreased firing of carotid sinus and aortic arch baroreceptors. This is fed back via the glossopharyngeal and vagus nerves to the nucleus tractus solitaris in the medulla and causes increased activation of the sympathetic nervous system and decreased activation of our parasympathetic nervous system. Via various mechanisms, such as the arterial and venous vasoconstriction, activation of the renin-angiotensin system, and an increased heart rate and stroke volume, causing an increase in both cardiac output and systemic vascular resistance, this leads to an increase in mean arterial pressure, attempting to keep it within the range that allows for organ autoregulation. In the perioperative period, anesthesia decreases the sensitivity of baroreceptors, reducing the response to hypotension and negatively affecting the feedback loop. In addition, it may also affect cardiac contractility and systemic vascular resistance, decreasing both, which will lead to hypotension. Surgical factors also impact hypotension and will include blood loss, surgical positioning such as steep head up, and other factors such as the presence of pneumoperitoneum. To treat hypotension effectively, it's necessary to understand the cause and apply the appropriate treatment. For example, if hypotension has occurred because systemic vascular resistance has decreased, then a vasopressor will restore vascular tone and increase our mean arterial pressure. However, if a patient is hypotensive because cardiac output has fallen due to, say, decreased contractility, then an inotrope such as ephedrine may be required. If cardiac output has fallen due to reduced preload, or the patient becoming fluid responsive, then a differing treatment in terms of fluid administration will be required, as well as an assessment whether that intervention will not only increase stroke volume, but also increase the mean arterial pressure as well. The appropriate therapeutic intervention to these situations can be guided by the use of advanced hemodynamic parameters, such as stroke volume variation, DPDT, and dynamic elastance. The use of stroke volume variation to predict an increase in stroke volume to a fluid bolus has been covered in previous modules, or previous lectures rather, and hence the focus in this one should be on the use of dynamic elastance and DPDT. We've seen that mean arterial pressure is the result of the interaction between blood flow and arterial load, for which we commonly use systemic vascular resistance as a rather simplistic measure. The calculation of SVR requires knowledge of the CVP and is subject to significant coupling errors, and the calculation of arterial load is very rarely performed. Dynamic arterial elastance, or EA-DYNE, has been suggested as a functional measure of arterial load, and it's the ratio of pulse pressure variation to stroke volume variation. It's essential to understand that this is not a measure of arterial load per se, but simply defines the dynamic interaction of two variables, that is PPV and SVV. This relationship defined by EA-dyne is affected by arterial load, but is not a direct measure of it. A similar analogy is that the preload responsive parameter stroke volume variation and pulse pressure variation are not direct measures of preload, but they too inform the user if the individual will be preload responsive. EA-dyne can be used to determine if a preload responsive patient, so that is the SVV is raised at greater than 12%, whether this individual will increase their blood pressure to a fluid bolus. EA-dyne defines the slope of the pressure-flow relationship, and knowledge of this can help us identify who will increase MAP to a fluid bolus. To determine whether a fluid-responsive individual is also pressure-responsive, vasomotor tone needs to be assessed. However, resistance is only one component of arterial tone, as vasomotor tone is a product of both resistance and compliance of the system. Compliance, or rather elastance, is the reciprocal of compliance and defines the change in pressure for a given change in volume, and this defines the pulse pressure stroke volume relationship. Dynamic elastance, however, or EA-dyne, is the ratio of PPV to SVV. For a given change in volume defined by our SVV, if this leads to a small increase or a relatively small increase in pulse pressure variation, then the EA-dyne is low, and the individual is on the compliant part of a pressure volume curve and hence very unlikely to increase their blood pressure to a fluid load. Conversely, for the same change in volume, if this causes a large change in pressure as measured by pulse pressure variation, then the EA-dyne ratio is high and this individual is on the poorly compliant part of the pressure volume curve. That is, there is high elastance, and giving a fluid bolus will increase blood pressure. EA-dyne has shown clinical utilities in a number of studies. Garcia found that in mechanically ventilated intensive care patients with preserved preload responsiveness, then an EA-dyne of greater than 0.89 predicted those who would increase their mean arterial pressure to a fluid bolus. Similarly, Ciccone showed a similar cutoff of 1.04 in patients that were spontaneously breathing. Fluid bolus above this cutoff increased mean arterial pressure by greater than 10%. However, they also applied the gray zone approach to this phenomenon and decided a lower cutoff value of 0.9 would be sensible. So it seems that in this limited evidence that spontaneously breathing subjects who are fluid responsive in terms of stroke volume will see a clinically significant increase in mean arterial pressure to a fluid challenge if EA-dyne is greater than 0.89. Additional work has been performed in the intensive care unit, showing that dynamic elastance has utility in weaning patients off vasopressor infusions. In this group of patients, if dynamic elastance, or EA-dyne, was below 0.94, then a set decrease in noradrenaline was predictive of a decrease in MAP of greater than 15%. The same group then went on to use this cutoff value of EA-dyne in an algorithm to protocolize titration of noradrenaline, and this led to reduced vasopressor infusion time and less time spent on the intensive care unit. There are some limitations of dynamic elastance. EA-dyne is a relatively new parameter, and caution is needed in its use and interpretation. It must be remembered that dynamic elastance describes the relationship between pressure and flow. It's not a measure of afterload, it's not a measure of SVR, nor is it compliance, nor is it resistance. It is simply EA-dyne. It should not be used to target a specific afterload. Secondly, to predict pressure response using EA-dyne, the subject must be fluid responsive, that is, SVV is greater than 12%. EA-dyne is not a valid measure of pressure response in preload independent individuals. In addition, work on pressure responsiveness is in its early stages, and there are limited clinical trials at present. Thirdly, true elastance varies with the degree of atherosclerosis and clamping during aortic procedures, and hence EA-dyne may not be valid in this situation. And finally, there is emerging work that is suggesting that EA-dyne is affected by both arterial and cardiac factors, and the normal arterial baroreceptor control system described previously affects the response to vasoconstriction and vasodilatation. For example, at higher MAP, any increase in flow results in a lower increase in mean arterial pressure. as the baroreceptor feedback limits this increase to protect the organism. Due to this, EA-dyne should be considered or used as a ventro-arterial coupling index that is influenced by arterial and cardiac factors. Nonetheless, use of EA-dyne can aid decision-making in the treatment of hypotension, helping decide which patients may respond to fluid and which may need vasopressor therapy or inotropic therapy. However, the other factor that's involved in maintaining MAP is cardiac output, and patients may be hypotensive without being responsive to a fluid bolus, either in terms of pressure response or stroke volume response. This will occur when either vascular tone or contractility has decreased. If contractility is first considered, this information can be derived from the arterial waveform trace. The arterial waveform shows the change in pressure over time, or dPdt, and hence the upslope portion of the arterial waveform represents contractility. The steeper the slope, the stronger the contractility, and the shallower the slope, the weaker the contractility. A true dPdt requires cardiac catheterization, or echocardiographic measurements. However, estimation of contractility using this parameter, derived from our radial waveform, can help guide our treatment of hypotension, particularly when the change or the trend in dPdt over time is considered. If contractility has been decreasing over a period of time and is measured by this parameter, then contractility, and hence stroke volume, and therefore our mean arterial pressure, can be increased by giving inotropic drugs such as ephedrine. Conversely, we know that if contractility is stable and a subject is not fluid responsive to either pressure through EA-dyne or flow via SVV or PPV, then a vasopressor can be considered if mean arterial pressure needs to be increased. As previously discussed, end systolic elastance is the slope of a line through the end systolic pressure volume point, so the upper left-hand corner of the PV loop, and is a measure of left ventricular contractility, and is the gold standard for measuring this. Changes in arterial dPdt and end systolic elastance correlate well in various volume status conditions. However, when the patient is underfilled, so for example PPV or SVV is dramatically raised, they do undermeasure left ventricular performance. We can use this arterial dPt, dt max to aid ourselves in the use of inotropes to treat hypotension, and it's not a parameter or a number that has normalized values. Most of the values that we consider or we see in the literature come from the cardiology work, measuring PV loops directly in left ventricles, and these don't correlate directly to arterial dPdt. And therefore, changes from baseline or trend values for arterial dPdt are probably the most useful measurements. There are some limitations in terms of using this parameter. As we mentioned before, this is from the arterial waveform signal. So if the signal is damped, so for example, a bubble and transducer, then arterial dPdt will be reduced and is inaccurate. dPdt or other measures of contractility can be affected by other factors, which include changes in preload and afterload. And as mentioned before, normal values for this parameter are not available in the literature, and therefore changes from baseline or trend values should be considered rather than absolute values. We should also exercise caution using this parameter in patients with severe aortic stenosis, since this may reduce the coupling between left ventricle and the afterload. The information that we have from all these dynamic parameters, from dPdt, fluid responsive, and EA-dyne, can be used together to treat hypotension appropriately. If hypotension occurs, the first stage is to ascertain is the individual fluid responsive, for example, by looking at stroke volume variation. If the individual is fluid responsive, the next thing we can look at is EA-dyne raised? Is it greater than 1, which is the optimal cutoff? If it is, that patient is a preload responder who, when we give them fluid, will also increase their blood pressure or their MAP to the intervention. If, however, EA-dyne is less than 1 or they are not fluid responsive, the next factor we look at is our contractility. If dPdt has been decreasing, then contractility is decreasing, and hence we give an inotrope, whilst if it isn't by default there, we'll need some vasomotor support to increase our mean arterial pressure. The effects of these therapies are assessed in terms of the impact on hypotension and further therapy given using the same analytical process if it has not resolved. However, hypotension is frequently treated reactively. That is, it's already occurred. The hypotension prediction index indicates the possibility that a patient may be trending towards a hypotensive event. The algorithm, developed using data from 13,000 past hypotensive events and over 12,000 non-hypotensive events, coupled with some machine learning techniques, detects potential hypotensive trending of a patient's mean arterial pressure. As HPI increases on a scale of 0 to 100, then the chance of an event becomes more likely. Now, the event that HPI measures is a mean arterial pressure of less than 65 for greater than 1 minute. So as HPI increases, the chance of this event hypotension increases and the time to the event decreases. Conversely, as HPI drop, the chance of becoming hypotension is diminished, and if it does occur, the time to this is extended. Here we see an example of HPI from a patient having a right hemicolectomy. HPI reaches a threshold of 85%, indicating a high possibility of hypotension in the coming minutes. And at this time, the mean arterial pressure is still adequate at approximately 80 millimeters of mercury. Hypotension is accurately predicted and occurs approximately 7 minutes later. The HPI platform provides information on EA dyne, SVV on contractility, which is displayed on the secondary screen, allowing the clinician to see changes in these key parameters in order to treat hypotension in the appropriate manner. HPI is predictive in nature, and therefore all the displayed parameters may show values, although rather the displayed parameters may show values that enable us to treat hypertension, they may also be in the normal range because hypertension has not occurred. However, the trend direction of these parameters may enable clinical decision-making to be used in advance of hypotension occurring. In summary, blood pressure is determined by a combination of cardiac output and systemic vascular resistance. And adequate blood pressure does not mean adequate cardiac output and vice versa. In hypotensive preload-dependent individuals, EA dyne can predict a rise in blood pressure to a fluid bolus. And arterial DPDT is a measure of contractility and can be used to guide clinicians in the use of inotropes to treat hypotension.